What do healthcare organizations struggle with in making social determinants of health data usable and actionable?
That is a good question.
Mark Taylor is the VP of Market Strategy at Ready Computing, a Medicaid strategist and the architect behind some of the most ambitious social determinants of health infrastructure in the country. He's helped stand up New York's 1115 waiver, shaped payer facing tech that closes referral loops, and built the backbone that lets community based care finally prove its value. Mark understands not just the theory of integration, but the workflows, funding levers, and data standards that make it possible. In this episode, we break down why most care models fail the 20% of patients with the highest needs and how the next generation of infrastructure is being designed to reach them. If you're serious about ROI, infrastructure, or funding social care, this is the expert you need to hear.
So, what do healthcare organizations struggle with in making social determinants of health data usable and actionable?
That is a good question. So social care data itself isn't as mature as clinical data, right? So you know that we've got all these coding systems, ICD-9, CPT-4, that codify the system. And social care isn't that easily definable. There are organizations like the Gravity Project, which is a subset of HL7, which is a standards making organization, that have created codes that are specifically related to social care. So being able to capture and codify the work that's happening in social care also helps you to get a better understanding of the needs for an individual that is the same across the platforms, like the same across the country, right? If you're using local codes, it's not necessarily going to equate to something that's happening in California, may not equate to something that's happening in New York. But the standardization of those codes helps to build up that reference data that can be used to really understand the populations.
It sounds like your approach to social determinants of health data, it's very localized, it's kind of custom to the population. And I know that you've done a lot of work in making it operational in real time. What are the biggest roadblocks to that?
I think social determinants of health it's a very hyper local thing. So, when you go to your doctor and you talk about, I have I have a problem, right? A physical problem. The social problems have a lot more stigma attached to them. I don't have housing. I don't have food. I don't have transportation. And it's sometimes very difficult for somebody to share that they don't have those problems. And then once they do share those problems, there to be no solution for them. So a lot of the work that's happening around the country or through Medicaid specifically, using the 1115 waiver structures that CMS and the states use together, starts to allow for funding for that at the hyperlocal level. So, for example, in New York State, we have 11 regions. They split the state up into 11 regions that know their communities and can dig in and build those relationships with people so that they feel that they have a trusted person they can go to and say, look, I'm having problems with education. I'm having problems with employment. I'm a diabetic and I don't have a refrigerator to keep my medication cold, right? Getting over that barrier and making that person feel comfortable enough to share that they have a problem is the first biggest step to getting those folks connected to care. The second half of it is, Medicaid itself didn't typically pay for this. It pays for office visit, it pays for labs, it pays for prescriptions. But if you needed help getting food box, or if you needed help with modifying your home because you're an asthmatic and you have mold in your home, that wasn't something that was traditionally covered under Medicaid. So now that these vehicles are in place that helps states approve coverage for these types of things, it removes the barriers for individuals to actually be able to access healthcare and improve their outcomes at the end of the day. If you're an asthmatic and you have mold or you have pests or you have other things in the home, you're going to continue to go to the emergency room, right? You're going to keep having these exacerbations until you resolve the underlying problem. So that's the second step, right? Getting people to open up. And then the second step is having programs available for them and funds available where they can use that to then fix the problem so that their cost of care goes down, their outcomes go up, and it's really a win-win across all of the different stakeholders.
So, yeah, it sounds like one of the most ambitious real-time case studies on operationalizing social care through Medicaid, at least that we've seen.
Yeah, the
And
one in, sorry, go ahead.
that's okay.
Yeah, I was just saying that the New York program itself is very ambitious. It's a multi-billion-dollar program, and they really tried to look at it holistically, right? To be able to close these gaps for people in the community that have those needs.
Well, you've come from a long time in health plans, and then did that influence your approach to the 1115 waiver?
Yeah, 100%. Medicaid itself, I went through a whole bunch of different roles at health plans, but the last one that I worked in was around quality. And it's about improving the quality care using scoring like NCQA and the state quality improvement scores. And that's where you have to start thinking about how do we engage with an individual to change the way that they behave, right? So if you want somebody to go to the doctor and have a service completed, in order to improve your scores, for example, for like an annual visit score or having your diabetes in check and under control, this was the missing link to getting them to the services that the person needs. I looked at it a lot like, there is the middle ground of where health plans offer services, and 80%, let's just say as a number, fit into that package, right? Everybody can get to the doctor, they can have the services performed, and they can control the costs. But then there are the outliers, and these are the folks that we're now going after to say, well, they're diabetic, they're uncontrolled, but we don't have any method to help them with the needs to improve their diabetes, right? We don't have the way that we can keep a child out of the emergency room because they get prescribed amoxicillin, which again needs to be refrigerated, right? If they can't keep it cold, it's not as effective. They go back into the emergency room.
I just wanted to ask if you found this video insightful. And if you did, please click on subscribe so that we can continue to ensure no one gets left behind in the value-based future of healthcare.
So from the health plan perspective, really looking at quality gave me a lens, like a prism that I could work with when I'm thinking about social care and how that can really impact the outcomes for quality and an individual's health needs.
So I guess you kind of come to the same dilemma that I think many of us like frontline social workers experience, where it's like the connection and, the getting the information from the patient and understanding the dynamics at play. That's all only as effective as the resources that we have available and the connection to the CBOs and the broader community as well.
That's right.
Does having that interoperability, like, can you kind of walk me back from like kind of getting that point where you can like how these systems help build up and maintain these relationships?
Yeah, that's a good question. So when you start thinking about just the CBOs that are in the community, the organizations that are providing those services, they come at a whole different level of maturity. You've got your mom and pop shops that don't have a lot of technology. You've got organizations that have a bit more technology, can do integration. You want to be able to meet them along their continuum, wherever they are in their maturity model, and be able to bring them to the table. So, building that consensus in the community happens through typically what in New York, they call them social care networks, right? They're established, they do the contractual work with the community-based organizations, with the managed care organizations, with the state, and then they basically take on all of that administrative work, right? So if you think about what happens let's just go to a medical encounter, for example. You go to the doctor does their diagnosing, they provide the services, somebody codes the service goes to the payer goes and reviews it. If there's an issue, they ask for more information. Then finally a payment goes out and it goes back to the doctor's office. A community-based organization has no idea what that process is like and doesn't understand the technicality of it at all. So being able to abstract that sort of work for a CBO so that they can work on the work that they need to do interfacing with a patient helps to bring them along, a little bit better. No, there are community-based organizations that will take that, a data feed directly and manage it that way. A lot of them just don't have the capability to do that. And they don't ever expect to have the capability to do that. So in some ways, it puts them at a disadvantage. It's how can they grow if they don't have the money to invest in the technology or the way to help manage the contracts and the relationships with the stakeholders in the system. At the same time, you've got the physician office, which is in a position to do that work too, right? So you've got a provider that could theoretically ask all these questions about health-related social needs and then do referrals out. But, physicians' time is limited. They, not to be cynical about it, but if they don't get paid money to do that work, it's very difficult for them to sustain that. If it's adding 20 minutes, 30 minutes to an office visit, well, it's going to push their schedule out. So having the capability for CBOs to work with physicians and screeners to work within those offices helps out a lot as well to bring people into the ecosystem around referrals to community-based organizations.
It sounds like it's creating this scalable, it's kind of like high volume system to what was once a really organic practice. It reminds me of like when my time working like out in the community and SNFs and in home care where, I would kind of have a smaller volume and I would get to know these patients over a longer period of time than in the acute setting. And then, I would slowly but surely start to get to develop relationships and partnerships with these CBOs, with other agencies, and kind of understand what their needs are, their capabilities are, understand like what they can handle, what they can't handle, and then, get feedback that way. But you've kind of operationalized that feedback loop too.
Yeah, that's right. A lot of technology organizations, they work to operationalize that because it makes it easier for the CBO to grow. There was I don't know if you know about an organization called the Gartner Group. They're a big think tank for technology and MCOs and that sort of stuff. And they had this idea a few years back about an SDHN, social determinants of health networks. And it started to catch fire a little bit because like a provider, a health plan contracts with a provider network. That's how that gets set up. They say, we're going to pay you this much. You provide these services, and they can agree back and forth. Well, bringing social care into that ecosystem, which is already well established, can go a long way, right? Being able to provide that infrastructure for them to be able to talk to the payers and even, the data that they collect working with a payer can be used for recontracting. They have data now. They have things that they can go back and say, we provided this much service and it provided this much help to improve their outcomes, or we had an impact on your emergency room utilization or your inpatient hospital utilization. Well, the payer is going to listen, right? They're not the big bully in the room, and not that they're intended to be the big bully in the room, right? But they do. They're the ones that control the money, right? So give power to the people, as they say, right, to the CBOs, to be able to go back and actually have a fruitful conversation with data.
Right. Coming up with that universal language and pathways to have, these partnerships as opposed to, silos and referral vast black holes. We refer, but we don't ever know what happens.
Yeah, that's a whole other problem, right? The black hole of the referrals. But they did build into a lot of these programs the idea that it's closed loop, right? This concept that it just doesn't go onto the ether and you never hear back from it. There's a responsibility that a referral goes out to a community-based organization. They have a certain amount of time they have to respond to. And if they're not, somebody's coming to knock on your door and say, something's not right. Like this person's not getting served. How can we improve this? So you can't fix what you don't measure. So that's the whole part of the closed loop referral. And I wish they did it for specialty care too. I think they're getting better at it, but just in general.
Yeah. Well, talk more about that.
Specialty care?
Yeah.
Yeah. So
what is the discrepancy?
Well, there's a lot of primary care that makes referrals out to specialists, right? And when a few years back, when we started to build our product, we were creating a product that does social determinants of health and is also a care coordination space, right? So a lot of the experts we talked to said, it's the specialist referrals are a big black hole. So a primary care physician will make a referral out to somebody and they'll never know if it's that they wait for the specialist to come back with their report, right? Or that the next time that they see the patient. So in between the time that the referral is made and either they get the report or the patient comes back, that person falls through the cracks, Look at something as simple as a colonoscopy. Somebody's going to get referred for a colonoscopy. Well, the person that you referred them to will try to call the individual a couple of times. And if they don't respond or they don't have the time, that topic isn't addressed again until the patient shows back up in the doctor's office. What if there's a way to create that closed loop mechanism that says, hey, you made a referral 2 weeks ago or 30 days ago for this patient, but they never schedule the colonoscopy. And then it kind of pushes the primary care physician to have somebody reach out again and try to get that individual into services. A little bit more onus on managing the risk from the primary care side or from the physician side to make sure that these services are completed. Because your other side of this is now the health plan is going to come looking at the primary care physician that they contracted with. And they have a measure for colonoscopy, for example, a quality measure. 80% of their health plan members need to have a colonoscopy every X amount of years. That primary care physician then is going to get pressure from the health plan to say, why aren't you people getting the colonoscopies if they don't close the loop on certain services? So that closed loop idea helps everybody along the way, right? It helps the patient most importantly, but it also helps the primary care that's dealing with the health plan, and then the health plan who's dealing with CMS to identify their scores and to keep their quality ratings up.
I want to go back to something that you said about risk. Do you see a relationship between social determinants of health and enabling funding, building infrastructure around social determinants of health and risk adjustment and quality?
Yeah. So there's a big, heavy question. There's a lot in there, right? So risk, from a risk adjustment perspective, you want to reduce the risk of your membership as much as possible from a health plan side, even a physician side. Physicians take risk, so they're responsible for the outcomes of their patients. An individual's risk can be reduced by eliminating those things in the environment that could prevent them from getting services. So it's the quote from Robert Wood Johnson: 20% of your outcomes are based on your genetics and going to the doctor, and the other 80% is everything about the environment within which you live. So if you can really spend the money and the time to help with that 80%, it's going to reduce that individual's risk tremendously. And a reduction in risk is a reduction in outliers, and a reduction in outliers is a reduction in cost. So at the end of the day, the whole theory is that by reducing risk, you're going to reduce the cost of care over time. One of the things that steps in the way of that a little bit is to get it started, to start one of these social care networks or start one of these sort of waiver programs costs a lot. There's a big spike in the beginning. So you'll see, if you were looking at a graph, it's going to go up high in your first year, and then it starts to level out, and then it starts to really have a positive impact on the cost of care delivered, medical loss ratios, all of that, state budgets. And with everything that's happening in Washington, there's a lot of cuts that are coming. There's a lot of reduction in available funds, and anything that can help to prove out that the work that's being done for social care has a valuable long-term impact on costs is what is going to save or destroy those programs, And if you're looking in the next year, let's just say we're looking in the next 2 years for cuts. Programs that are just starting up, they're not far enough along to show value. So do they end up on the chopping block? Or other states like North Carolina, Healthy Opportunities Program, which is now, they hit their peak in the beginning, and now they're starting to level off and they're showing some real value on the other end of it. Do they become the poster child for every other sort of social determinant of health, social care value proposition. From a risk perspective, that was probably a long-winded to say it, but yes, there is a
It
huge
was gold.
impact on social determinants of health and improving an individual's risk.
So, how can leaders best prepare for the next couple of years?
Oof. It's telling that story loud, It's, in my opinion, it's like, don't take your foot off the gas. Keep pushing, because at the end of the day, it's working. We see it working. We know it's going to work. And, I would wager to guess that in the next couple of years, HS and CMS are going to start looking for those organizations that do this well, so they can start touting them. So it's a double-edged sword, right? Because on one hand, they want to cut all this money and cut all this budget, but let the programs speak for themselves. And they're going to come and look and they're going to say, the program here or the program there saved this much, which is you can't argue with that. It's not something that's easy to cut. And it also ties into, they're cutting a lot of programs that don't have direct member or patient impact. So if it doesn't impact the member or the patient directly, they're more likely to cut it. And so there's some very important programs they're talking about cutting, like there's a shortage of primary care physicians. So there's a lot of educational programs that are happening to try to get more PCPs in the workforce. But those that are hitting the patients directly, like social determinants of health, I think that they're almost like a political third rail. If they start doing that, it might cause more damage than good. And I think hopefully they realize that as well.
So with CMS proposing to cut out social determinants of health data collection, I think that just happened like earlier this month. Do you see healthcare systems needing to adjust their strategies for addressing social determinants of health?
They have to reconfigure how they think about their spending their dollars. So for Medicaid, for example, Medicaid managed care plans, and I think fee-for-service is its own thing, right? That's sort of like the insurance of last resort. But when you get into managed care for Medicaid, there are a lot of different tools that they can use to help to keep this going along. And at the end of the day, it's going to be the state and CMS that are going to turn around and say, yes, we want to continue this program. Because remember, these 1115 waiver programs run 3 to 5 years, and then they have to get re-upped. Right? So they go back to CMS and they do the dance again and talk, we'd like to extend this program further. Or if they can't extend it, those social care networks need to figure out how to be self-sustaining. So if at the end of the 3-year period, let's say in New York, they realize that there is a significant reduction in emergency room, so we've averted funds that would have previously been spent for emergency department or emergency room activity or inpatient hospitalization. Well, now that kind of frees up some money to do some other things, right? So maybe the value of the program will be determined based upon the money it saves at the end, and that can be reinvested into the health system.
What do you think would likely happen if health systems say, this is too much, if we're not required to collect it anymore, we're just going to kind of retreat and, kind of pull back on any other development we have in that arena?
Yeah, I don't know if they can. It's very obvious. And look, that in healthcare, in managed care, and in the state, it's a lot of underwriters, right? It's a lot of statistical people. And they're going to look at this and be able to extrapolate very quickly that, look, the work that's being done is going to lower cost over time. So for them to pull back from it and say, we're not going to support it anymore, I think that's a slippery slope. And I don't think they're going to do it because I feel like the value is going to be strong enough that they're going to stick with it. You also have to look at all the infrastructure that's getting built out to support it today. There's the idea of the community information exchange, which, most states already have a health information exchange where they exchange the clinical data. So that as you go from one doctor to the next, it shares all of the data. Well, the same thing's happening with what they're calling community information exchanges. So the social needs now bubble up and everybody knows what that individual's social needs are. So when they're making a prescription, when they're figuring out what a care plan is, they know what all of the problems are. And going back to my original, statement, they still need a way in order to close those things. So hopefully the states, the Medicaid organizations, even grant funding can help to keep those supports floating afloat.
So, it sounds like we're kind of looking at this crossroads of what like healthcare systems need to kind of decide what they're going to be to the organization, like, what they're going to be to their local communities and in like
Yeah.
what capacity as well. Do you see like leveraging partnerships with CBOs being more relevant now?
I think they have to be part of the ecosystem. Once you start seeing the results from this and start to realize how important they are to the end game of someone's physical and psychological and like all of their health, this whole person care that we talk about, they are really key to coming to the table. There's also this concept of lifestyle, and I forgot what the word is, but it's sort of like, you've got your clinical and you've got your social determinants of health and your mental health, and all of that kind of falls together into this bucket of lifestyle, right? We all know that the lifestyle things that you do will impact your outcomes, right? If you eat right, if you exercise well, you meditate, you get rid of stress, all of those things are 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 so interconnected that it's an area that sort of gets bolted on to this idea of clinical and community-based organizations. That's why you see it in a lot of health plans. They bring up these things like, you've heard like the app like Calm or other like breathing apps, and they teach people to box breathe and all of that. It's all fitting into this whole idea of lifestyle that includes whereas it's not sick care, which is what we do a lot of today, it really is holistic lifestyle healthcare. And that's, the holy grail for individuals to maintain and improve their health.
So we have like that idea of the whole systems thinking along with to match the whole person kind of perspective. What's the typical roadmap that a health system can look at when they're trying to scale things like that care coordination?
It usually depends. A lot of it follows regulation, right? So as regulations are passed, they can take advantage of that. So, health systems being able to make sure that they are investing in figuring out how to get those social networks incorporated into their workflows, right? It shouldn't be an afterthought. It should really be part of their flow. So, when you start thinking about systemically, it's this the old concept of like study, what is it, study process, I got to remember my acronym, but it's an old nursing school acronym, and you may have even had it when you were studying to be a social worker.
Now the PDSA, is it?
Yes, plan, do, study,
Okay.
act. Thank you. So it is the idea of planning, right? You've got to figure out what your needs are, then you've got to study it and figure out how to do it, act it, and do it, and then rinse and repeat again and again until as you perfect it and get it right. The human beings they're not machines, right? They're not really that predictable. So thinking you're going to do a one size fits all, it's just not going to work. Everybody has their like web of specific needs, and having enough support for people to find their way is key for healthy, happy living.
I think I really love that you apply that concept of, the age old quality improvement kind of standard to the care that needs to happen outside of the walls. And because I think that's something that, a lot of people don't kind of take into account, that health doesn't start within the four walls of the hospital. So obviously, the ways that we improve health outcomes kind of need to be conceptualized in those out of hospital settings as well. That's
Right.
really
I mean,
cool.
the real goal is to stay out of the hospital.
That's the point. That's literally the point. Yeah.
Historically, it used to be heads in beds. That's how hospitals made money. As I have a census, and that's how I make money. But now hospitals have to think differently because heads in beds is not what they get reimbursed for that well. It's more about keeping people out of the hospital who gets a hospital acquired, issue, and they go home and they have to come back. So, and you don't think about it, but some of these issues can happen at home after you get discharged if your environment isn't set up properly, right? You have issues in your home. You've got cold or heat related issues, and that can exacerbate your illness and send you back to the hospital, right? The opposite is true for primary care, though. You want people to go to primary care. You want people to get to their doctors and do the preventative work that needs to be done, right? And make sure that they're okay. Catching something before it gets big. My father used to be a very big proponent of, he's like, get a problem when it's small before it becomes big. And, don't avoid it. Like, address your problem early on. And you see that, like, even any cancer treatments, medical problems that individuals have, the sooner you catch them, the higher probability you're gonna have a better outcome. Same thing with social determinants of health. You don't have heat in your apartment, or you don't have electricity, right? You can get by with that for a very short period of time, but if you fix it, you're gonna fix the bigger problems coming down the road.
I've kind of have had that thought about like social care as quality improvement, just in the saying, like, you want to get, what is it, the right care at the right time for the right person, right? So because these things like the poor social environment, poor social supports, poor resources, and that kind of thing, what they show up, and they show up as the ED visits, the readmissions, they show up as that those quality metrics that occur like inside of the hospital as well, as we've kind of have said.
That's right.
So does an organization need to have like a big tech stack already on deck in order to start scaling and operationalizing social determinants of health data?
No, probably not, right? What I think is surprising is a lot of that conversation around social determinants already happens. So, from working in an ER, somebody will come in and they'll have a problem, but then you'll find out all of these other things about them, right? And then what do you do with that? Well, like, oh, I know this shelter, or I know this place that you can go to, or let me get you to a social worker that can send them here or send them there, right? So you kind of see how that network sort of works already. To get the real value out of it is then to start thinking about, well, how do we collect and measure social determinants of health, just like you measure a quality metric? And in fact, NCQA has a quality metric that they introduced recently around screening and navigation. So they're starting to tell the health plans that you need to start paying attention to screening and navigation. Now, out of the gate, there's probably not a lot attached to it. There's not like a quality incentive bonus that's associated with it, but I think it's coming. I think you're going to start seeing, like, you are in the top tertiary of for screening and navigation to services from a health plan. They will start putting more money into it, which then forces the systems to start putting more money into it, right? So all of that, it all feeds together, right? I guess at the end of the day. And going back to, you can't improve what you don't measure. There's a lot of smart people at NCQA. There's a lot of smart researchers that really dig in and figure out what's going to work, what has value and what doesn't have value. I think organizations should take advantage of those learnings, help them focus their priorities with that kind of information.
What's the biggest gap between what organizations can offer and what health systems are prepared to support technically?
I think that depends on I think it's a very local question. Some areas may have a larger problem with just getting to the doctor's office. It might be a transportation problem. Some areas, like when you get into the rural communities, it may be as simple as access to care. You may not have everything that you need out there. And the richness of what you might be able to do for a social care network may be lacking too. So I feel like those needs are so very localized that it could mix. There could be a mix across this kind of the standard things that we know about that fall into the social determinants of health space, right? We know housing is an issue. You've got housing problems, which are things that might be going on in your home, like if you need ramps or you need bars in your shower, like environmentally things that you do to your home to make you safer. And then you get into nutrition and safety and education and employment. And I think there's a different mix for every area of those things, right? So I don't know if it's easy to pick on one. However, I guess I will say that I see a lot of states and other areas kind of focus on food. And we've seen food being like one of the biggest drivers and needs that are getting fulfilled. Like when we look at some of the work that we're doing in New York State, and you're seeing the services where people are taking up the offer, a lot of it has to do with food, transportation, and housing. right? To be able to get to your appointments, to be able to, right, to have food in your home, proper food in your home, right? The right diet, getting access to those things.
Makes sense. So for organizations that don't have that big tech stack on deck yet, don't have maybe all of the data that they need just readily available, what are some easy wins that they can make that they can do now to make the most of what they do have?
Yeah. So some of it is understanding how people can get connected to them. Right? That's the first step. How do they get people connected to the community-based organization? So that's having the conversations with the hospitals, having the conversations with any organization that might be able to make a referral to them. And sometimes the referrals are just an email. It's like, hey, I've got somebody, they're going to come see you, right? Or a secure message would be ideal. And then you start to grow into these technical, right? These more technical solutions where they can start doing referrals electronically, right? Find out what infrastructure may already exist in your area and then start utilizing it. You know, there are competitive products to ours that offer tools that are free to the end user. There are lots of different ways that you can connect it to the ecosystem. So I think it's understanding who you're, it's like any almost business venture where it's you want to understand your customer and where they're coming from and make yourself known so that you can bring those individuals in. And you may have a little bit of a struggle getting reimbursed for it if you're using Medicaid. If you're grant funded, it's a different thing. Right? You've got funds available to you and you continue to chase the grant. But talk to the MCOs, talk to managed care and find out, what do you offer? What can we do? There's this other concept called in lieu of services, ILOS, which allows billing for certain things, and certain managed care organizations can use that for things like nutritional meals and other things, right? So it's a good place to start. Talk to the people in your market and find out what opportunities are available, and then start thinking about the technology.
That makes a lot of sense to me that you would say that, because from looking at what you've done in the past, it sounds like you're someone that kind of is all about like the workflow matching like the theory so that the tech fits the day to day and not really like the other way around.
Yeah, don't let the technology drive the outcome, right? Technology enables. If you don't have a good grasp of what you want to do, technology can really mess it up more, right? At the end of the day.
I love that. And it's so true, because from the user side, like myself, like being a frontline worker, I see a lot of like good ideas and tools that are sort of like available, but they end up kind of shelved for a long time, and kind of nobody really knows what it does, what it's supposed to do, or how it's supposed to integrate with the workflow, or it's too clicky, or it just takes up too much time, or just ends up defeating the purpose that it's trying to solve.
Yeah.
So it's kind of like, it feels like, these are symptoms of misaligned workflows.
It could be misaligned workflows. It can be misaligned priorities. It could be not understanding the problem. So, we as humans tend to solve before we analyze. It's like a problem comes your way and you go right to the solution. We'll take that step back and say, well, what are we really trying to solve here? I think it was it Einstein or somebody said at one time, if you can't explain a problem like you're talking to a third grader and they understand it, you don't understand the problem yourself, right? So, and it's true, the simpler you can make it and the clearer you understand that problem, the better your solution is going to be. And it gets complicated because these are things like social determinants of health that don't have a lot of, structure around them. Everybody's got a different problem. So how do you have enough variability in your process that you have room to help people where they need help? Not like, here's the box that you have to fit in to solve your problem. It's like, here are the tools that I have that can help you solve your problem. Let's find the right mix and then go implement them.
What are the metrics you use to prove ROI?
The biggest one is outcomes, but it does start with some process metrics, right? How many people did you get a hold of? How many referrals did you make? How many closed loop referrals? And then outside of those process metrics, to make sure that you're dotting the I's and crossing the T's, it's the outcome metrics. did for this population compared to a population that was not served through a social health process, what do their outcomes look like? Is their ED utilization the same? Is their inpatient utilization the same? What about their chronic care management? Right? What about all those other costs that go along with it? That's really going to drive identifying the impact of social care. And there's probably as simple as, the net promoter score, right? Would you recommend? There's probably a same sort of proxy that you can do. It's like when you started the program, when you started in the program and when you ended the program, how do you feel different? Right. So there's a little bit of those subjective measurements that you can put in. How do you feel your life is after you've gone through this? Right. How do you feel your health is after that? So aside from the hard data of outcomes and ER visits and very specific data, that subjective data has a big impact as well. And that's how you can use to measure the success of a program, is by understanding both of those subjective and the actual data components.
So now maybe you can help me with a problem that I hear a lot. I've had a few community health organizations reach out to me, just like finding my stuff on LinkedIn and saying, we love how you break down ROI, and you break down like the costs of a care delivery and impact and all that kind of stuff. And can you help us do that for our organization and how we're benefiting our local health system and that kind of thing. And so when I'm helping these nonprofits, a lot of like what I hear is, they might be saving their health systems like millions. They might be doing like in the trenches, tons of work, meaningful, good things, and producing these positive outcomes. But they kind of rely on kind of donor funding that, as you know, can fluctuate, come and go. And so even as a social worker myself, for 10 years, I've had so many like really good organizations that just kind of like shut down from one day to the next because, and so proving the ROI becomes a really important part of that conversation. And so you need to have this is just me like on my soapbox now, you kind of have to have that ROI, or at least the language of how you're going to go about the ROI, or that you have that vision in mind. Sure. To engage these health systems and sort of like develop partnership and that kind of thing. So I guess that was my, I don't know if that was a question or more.
No, but it's a good point, because if you think about the way that health plans are going to measure this, they're going to use the administrative data that they get from claims across the entire patient spectrum. As a CBO, you don't have that. What do you have as a CBO, right? I called them, I got a hold of them, I connected them to a food pantry, I have some subjective data, I have a relationship with them. Do you know if you prevented them from going into the hospital? Do you know if you prevented them from going into a crisis? Did you improve their quality of life? So it's a real blind spot for community-based organizations to try to figure that out when they're working with funding from a plan, for example. I guess there are probably some tools that they can think about, some analytics tools that can extrapolate some of that, right, from a population perspective. Like you can know that I've got, these are the amount of pregnant women, let's say, that are in my program that I'm working with. How many of them had a bad outcome after, the birth and, doing the prenatal and postnatal versus had a good outcome? And can you tie that back to them? But again, it's very difficult without all of that administrative data. I think the way they get to that is the partnership with their managed care person or their managed care organization to say, look, we've got this data, you've got this data, let's put them together, right? Which is kind of what's happening in New York. And I think it's also happening in North Carolina, but these social care networks send claims in, right? We mentioned a little earlier. They send claims in, which says this person has this diagnosis code, like they're homeless or they don't have the Z codes, which are identified by gravity. They send that in. So now the data is married together. And while they're contracting with these community-based organizations or contracting with managed care, they need to get access to the outcomes. Right? Without having the access to the full gamut of the outcomes, they don't get to see the full picture of what they're doing and how they're actually improving helping to improve that managed care organizations' population health and decreasing the cost.
That's a lot. That's amazing. I guess I want to end off with a final question. Do you have any best practices for closed loop referrals that you've seen so far?
Yeah, I mean, it's really statusing and paying attention to the status and escalating. So that referral goes out. You need to have a checkpoint in a couple of weeks to make sure that it's getting completed. If it's not getting completed, there should be outreach activity to find out why and try to resolve any barriers that are preventing that from getting completed. Or if the organization that you're sending this to can't complete it, that's a point where you could redirect that referral to another organization that might be able to support it. So it's really just it's basic blocking and tackling really at the end of the day, and then having the time and the authority and the ability to do it. So depending on the volume of people that you see, that may not even be practical, right? If you have a big population and you only have a couple of people that are doing that, you got to figure out where you're going to spend your resources and your time, come up with some automated ways to do that. There's even, AI that can help try to figure some of that out, right? So there are tools and there's technologies out there to do it. It's, again, understand your problem and then you can find solutions for it. Like, why are my referrals not getting closed? Is it one organization? Is it these 3 specific organizations I have a problem with? Go talk to them, right? Find out what's going on with them and see if there's a way that you can make that process easier. But nothing takes away that conversation between the stakeholders, right? That's the problem with a referral that doesn't get closed. You send it out, and if nobody takes responsibility for it, or if the organizations that are rallying around this individual who has a need isn't taking collective responsibility for it and not talking to each other, it's not necessarily going to happen.
For sure. Yep. That the accountability in place, and also using these processes to kind of build more ease and predictability in creating and maintaining these ecosystems of kind of community health.
Totally. Yeah. I mean, it's still new relatively, so everybody's finding their own ways. And hopefully the best in breed bubbles up and becomes sort of the normal way to do things.
We can hope and pray, but
Yeah. Right. That's right. Well, like I said, just keep their foot on the pedal and keep moving forward and realize that, I heard somebody speak at a conference last week and they said, all the stuff that's happening with the government and they're like this, they're removing words and they're removing this. The work doesn't change. People still need help. You'll figure out how to do it. You may change the way that you say it. You may change the way that you do it, but the work doesn't change. And you'll find when there's a will, there's a way. You'll find a way to do it.
right. As we talked about, the social determinants of health don't disappear just because we stop tracking them.
Right.
If we do,
That's right. Yeah.
that's
So.
a great rally cry for me and for the audience here. So, I want to thank you so much.
Well, thank you for having me. I appreciated the conversation and the time to talk about something I'm very passionate about. So thank you.
It shows. Hope to have you on again soon.
All right. Very good.
Bye.